Hi, my name is Janie. I've been an ultrasound technologist for about 10 years now, working here in the States. I have my bachelor's degree in diagnostic medical sonography, and I specialize in OB/GYN and small parts. Mostly, I do hospital work and some clinic work as well. So today we're going to be talking about first trimester OB and some of the pathologies that we can see associated at this point in gestation. So it's my understanding that you guys have had some training on ultrasound in regards to the pelvis. So we're just going to do a little bit of a recap on that for right now. I suspect we have a wide range of experience levels in regard to pelvic ultrasound. So let's just touch back over that for now. So if we're starting, just look at this. It has a little 3 next to it, the image kind of at the bottom, just to help orient and remember where we're at here. So we can see the bladder, it's that anechoic structure. So it's going to show up black essentially on the ultrasound screen. So that's going to be our bladder right there. And then just behind that, you'll see the cervix, which leads into the uterus. They have some grayscale on this drawn image as well, where you can appreciate the endometrial lining is this lighter color here. You can see the vaginal stripe, and then of course you're going to have all this extra bowel off to the side. Now transitioning into the ultrasound image itself, just above that caricature essentially, we have again the dark color, the anechoic bladder structure here labeled BL. This is a transabdominal sagittal uterus image. We can see that nice uterus lying behind that right here. You can see that this is the myometrium we're able to appreciate. And then this thinner, lighter color, that's the endometrium right there. So this is just a regular pelvis. Not a pregnant patient, or at least not very far along. But again, just to help orient ourselves. And then we have this image on the right, same thing again, that nice anechoic bladder. You can see it's causing the uterus to stretch out as the fundus is distended down because the bladder is full. So that's just something to remember, if you're doing a transabdominal ultrasound, especially if you don't have the capability to do that internal portion, to make sure the patient has a nice full bladder, as it's going to lengthen out your uterus and allow you to visualize it much better. It's also going to give you a better angles for the sound beams as they come across the uterus. If the uterus is pointing straight up, those sound beams aren't going to be able to obtain a good image of the uterus and the contents within it. So you want to have it stretched out with a distended bladder there. So in these images here, we don't have a good visualization of the ovaries because we are sagittal. We would need to angle out to the right or the left to see those ovaries. I'm sure I have that in another slide somewhere. Okay. So again, this is just some help orientation here. We can see again, here's the bladder. We're coming straight down. There's the uterus. So this is a perfect image to show how this study would have benefited by a distended bladder. This bladder is clearly empty. And because of that, the uterus is essentially pointing straight up towards the transducer, which would make it quite difficult to image it accurately. You probably wouldn't get an accurate endometrial stripe measurement. You might still be able to see the gestation well, but just for uterine visualization in general, this is not the ideal position. I just also have to point out that they're using a linear transducer for this, which is quite obscure. We would definitely use a curved linear as opposed to this flat linear here. So let's just touch on the points here. We have our uterus, of course, our endometrial lining. A couple things we're going to talk about: double decidual reaction of the gestational sac, crown rump length, fetal heart rate. We'll touch on yolk sac. And then one of the most important things, in my opinion, for this topic is going to be the ovaries and the adnexa. Because, of course, our concern here is to evaluate the patient for an ectopic. it's great to be able to find baby and determine gestational age and, of course, estimated due date based off of that information. But our primary concern here is to evaluate and make sure that this patient doesn't, in fact, have an ectopic pregnancy, because that's going to be life-threatening. So double decidual reaction here. This is not a make or break finding. It's just more something to be aware of. It can help you determine whether or not you're visualizing a true gestational sac. However, I place a lot of hesitation on making a leap that something is an actual gestational sac as opposed to free fluid or a pseudo sac within the uterus itself until you can see a crown rump length. So a double decidual reaction, if you look at this right image here, you can see this bright line coming all the way around that anechoic structure. That's the gestational sac. And you can see that on this right image. On the left image, you'll also appreciate some fluid within the uterus, but we're not seeing that nice bright circle around it. It doesn't have to be round, but that nice bright lining around that anechoic structure there. We don't appreciate that on this image. So I would put some hesitation on calling this a gestational sac. Of course, it might appear differently in other images, but in this particular situation, it's not a gestational sac. It is just fluid within the endometrium. And then this, we'll talk about the posterior cul-de-sac as we go along. This is the area we're referring to primarily. It's due to gravity that fluid likes to accumulate in this cul-de-sac right here. So that's something that you're always going to need to be aware of. And it can be a little bit more difficult to evaluate just due to the distance from the transducer. But it is really important to evaluate that area. So let's move on. So here's a little bit better demonstration of the double decidual sac sign or double decidual reaction. It's referred to in various different verbiage. So this is a nice little chart here that shows you the different layers. We can see the gestational sac here in the middle, and we'll work our way out. And the reason that you're getting that nice bright circle there with almost like a hypoechoic ring on the outside of it before you get to the endometrium and myometrium area there is because of these different linings here. And that's just what this image right here talks about. So just a point on here, if a double decidual sac sign is present, then it is highly suggestive that the uterine fluid collection is intrauterine pregnancy. That being said, again, I would not make the leap until you can see a crown rump length. It's just kind of too subtle of a sign to really bet on. Okay, so some orientation now for endovaginal ultrasound. Up until this point, we've been imaging, that's actually an EV ultrasound. These are all going to be transabdominal ultrasounds right here. Again, so just coming right below the umbilicus to obtain these images here. But another method of obtaining similar imaging without a lot of the bowel gas issue that we have is going to be this right here. So this nice little diagram here will show you, you insert right up against the cervix, and now you just have to realize where your orientation is now. So now your bladder, if we're looking at here, this would be your bladder up here. It's not in this actual image, but that's where it would be. Our cervix is here coming down to the uterus, and then we're going to visualize the endometrial stripe right here. It just kind of helps us orientate a little bit better. You can kind of see in this one here too, where they put the bladder here. It's a really weird drawing of the uterus, but just some orientation to help you out with that there. So let's touch on a retroverted uterus. They can be a little bit tricky to scan initially, just because everything's kind of backwards. So as long as you can just kind of place yourself in the position and understand really what you're imaging and where you need to go, it'll be a lot easier than if you're just in a monotony of scanning, which I suspect you guys would be more ready for that kind of a transition. But just to remember, your cervix is going to be essentially at the same spot, but then of course your fundus is going to drop back the other way. So this looks retro. So I think the cervix is retro and the uterus is retro. This is a transabdominal image here. But now if we move to the endovaginal image, you can see the cervix on this one. Maybe it's retro. You can also have an anteverted uterus or cervix, and then the retroverted uterus, and that can get real tight in there when you're trying to get the imaging. It just takes a little bit of searching to kind of get the hang of it there. So in this image, we'll see the cervix. You can see the lining right there, and then you can see the fundus wrap around. This is the myometrium, endometrium once we get a little bit lighter. And then we have our gestational sac right here. And looking at this gestational sac, the borders look a little jagged, but it very well could just be the slice that we obtained on that image. We'll talk about that some more later as well. So when we're looking at that gestational sac, just some things to help identify here. Again, of course, myometrium. This is the gestational sac. You can see that double decidual reaction on this image, particularly right up here behind the words. You see the bright line, and it gets a little bit dark on the other side, just to see that. This is that nice yolk sac. It almost never shows up this clearly, but it can. This is nice and round. I'm not going to touch too much on the yolk sac. Studies that I have gone over don't seem to place a lot of thought into how much the imaging of the yolk sac can really contribute to reaching a diagnosis of anything going wrong with baby. So we're going to spend most of our time talking about other things, but you can see the little duct here, and then we have our embryo. This is going to be the head. This is going to be the rump. So we would measure our crown rump length from this tippy top here down to the bottom here. You can actually see the umbilical cord on this one, inserting right into where that placenta is going to be forming right here. This here is the amnion. So I do want you to be aware of that. Oh, we have a nice picture of it over here. You'll see that very often. Honestly, mostly I want you to be aware of it so you're not concerned that it might be something else. I've seen it miscalled as some weird stuff. So this is just the amnion. It's going to grow in with the chorion as baby progresses, but that's what it looks like at this stage. So I think this is a nice little picture here just to help us understand exactly what we're looking at right there. Okay, so here's some measurements of the crown rump length. Uterus here, this looks like a transverse transabdominal image. So is this one, and then this one down here is an endovaginal image. You can tell based off of the field of view obtained with the transducer. This one's cut off about here, and this one comes all the way out here, just due to the shape of the end of the probe. So coming back here, we have baby's head. This is nice little, you can kind of see a profile right here. A leg, that might be a cord there. We just want to make sure, of course, you're stretched all the way out, coming all the way from the head to the rump, get that nice measurement there. I usually take 3 and take an average, but they're almost always the exact same measurement 3 times. You'll see this hypoechoic structure, that dark area right there in baby's brain. That's the rhomencephalon. We will touch on that here in a bit. There's another one, and there's another one. You can see the developing rhomencephalon right there as well. So let's see, crown rump length. This is going to be the most accurate way to measure baby. So if you can measure a good crown rump length first trimester, you're not going to want to change those dates later on. If baby is not progressing the way that you're expecting and those dates don't line up further along in pregnancy as what you obtained early on with the crown rump length, that's going to be a developmental issue. And you should not be adjusting your EDD based off of those later measurements. Let's see what else we have on here. Yeah, basically this is just all touching on the significance of this measurement and the accuracy that it provides. So super important there. It's really nice, especially again, as baby progresses, we want to make sure that they're sticking around the sizes and dates that we see at this early stage. Okay, so ovaries. The reason ovaries are so important in early OB ultrasound is we always want to make sure that there is not going to be an ectopic pregnancy. So ovaries also, theoretically they could get torsed in an early pregnancy. I'm not sure I've ever really seen that, but that doesn't mean that it can't happen. We routinely look at the ovaries just to evaluate for torsion every time we do a scan. It's pretty simple, and if you do catch it, you could save them. Kind of a big deal. So this is the ovary right here, right there in the center. Easiest way I have found to find that is to go transverse, come all the way up to the fundus of the uterus. You can kind of see it start to go to a point off to the adnexas and then just follow that. And most often you will find your ovary right there. They can be tricky little boogers to find. Just remember to be looking for those nice dark follicles, all the little dots in there. Generally, with a pregnant patient, their ovaries aren't going to be super small since they were able to get pregnant. So they're usually a little easier to find transabdominally or endovaginally, as long as the pregnancy hasn't progressed too far to get them squished and moved up. But do keep that in mind that they will progress in their location a little bit. So when we're evaluating the ovaries, we can see like the corpus luteal cyst. That's probably what this is right here on this transright ovary picture on the right. It's just going to be that hormone cyst that grows with pregnancy. Generally, they're gone around 15 weeks or so. They can progress all the way through pregnancy, but most likely they'll drop off end of first trimester or early second trimester. So when we're looking at the Doppler of that ovary, again, we're going to be looking for this high resistive flow. So you'll see that peak here, and then the diastolic is going to be fairly high as well. What did we get this one at? 0.56 for the resistive index on this one. So as long as you're below 8, 0.8 probably, you most likely are in the ovary. If you don't have as clear of an image as this, evaluating for that high resistive flow can help you determine whether or not you are obtaining ovarian flow versus uterine flow, or even bowel flow, which can also be high resistive. But so try to stay in the ovary, make sure you have that nice high resistive flow that's indicative of ovarian flow. So these are those nice pretty ovaries. Let's move on. So fetal heart rate. There's something we call ALERA, as low as reasonably possible. So there's multiple ways to obtain a heart rate, which I'm sure you're aware of. The pulse wave is going to be one that's often used for, that's what this was. This is pulse wave right here. So, you can see like a typical heart rate where you can see the systolic and the diastolic and measure the resistive indices. And you can kind of see it pumping like we would see almost in an EKG or something. This is M mode. So M mode does not use as much power as pulse wave does. So the beauty of M mode is that we can stay as low as reasonably achievable when we're sampling baby's heart rate here. So lots of places, most places where I work, we don't use the pulse wave, which is this guy here, on baby's heart rate, just to keep any possibilities of cavitation to a minimum. We don't want to expose baby to anything that they don't need. So this is M mode here. You can see my machine here was set on 1 round of heart rate. Sometimes they'll be set on 3. So you can see, come on. This black here represents this area here. So this is gestational sac, gestational sac. You can see the color changing. Woo. It gets a little bit more echogenic here. And then as we come down, you can see right about there, that's where I'm getting the heart rate. And right here. So it's pulsing right there. So we're gonna measure that heart rate. It really doesn't matter where you measure it. Looks like I measured peak to peak here, but as long as you measure the same spot in the cycle, you'll get your heart rate. I kind of have 2 drastic ends here. We have 100 beats per minute, 171 beats per minute. Technically, both are within that normal range of 100 to 180. This one doesn't look that early, but generally when they're really early, their heart rate's going to be lower. So if you have like a 6-weeker and you're just barely seeing that heart rate, as long as you're hitting 100, you're probably still in a good place. Sorry, my dog is losing his mind. You do want to make sure that you're not obtaining mom's heart rate at the same time. Ideally, her heart rate would not be over 100 laying on a bed, but just also another thing to be aware of if you are getting a really low heart rate. These ones are a little bit harder to pick out, but it is, I feel like it's still important to try to use the M mode when you can. So again, that's all this is M mode. We want to limit cavitation, do what's best for baby here. Yolk sac. So again, even though I don't feel like this is a super important marker, especially in first trimester and what you guys are going to be doing, still something you want to be aware of. This is the yolk sac. It's that nice little echogenic circular structure that you will see within the gestational sac. We do measure it. There's one there. So this is another thing that you're going to want to be aware of. This is called the physiological gut herniation. So around 6 to 8 weeks, proceeding to about 12 to 13, the gut leaves the abdominal cavity, comes out, twists around and stuff, and then it'll go back inside the abdominal cavity. So it can be a little bit concerning when you initially see this because it looks like something terrible is going on. But it's just the normal way that the gut develops. As long as you're seeing it early like that. Later on, that would certainly not be normal. And then we have omphalocele and a lot of other things to be concerned about. But at this early gestational age, totally normal. Just a couple things to point out here. We can still see that nice, pretty amnion coming right around here. Again, this is later going to fuse with the chorion, and we won't be able to appreciate that. So if you can see it like this, it's likely indicative of an early gestation. We're seeing a small, this looks like a transverse abdomen, of course, because we can see the gut herniation here. And then we do still see this nice little yolk sac right out here. And this is a nice measurement of the fetal heart rate. I don't know. It's not super easy. This isn't one of my pictures. It's kind of hard to see the fetal heart rate there. But picking them out on these still images is a lot harder than seeing the heart rate yourself. When you're obtaining it, it's a lot easier to, watch for the changes on the M mode and pick up the heart rates on there. It's easier than finding someone's study later. So here's that rhomencephalon we talked about. You can see this nice dark anechoic structure right within the brain there. This one's even nicer picture. That's just a nice picture. The whole gestational sac is nice and anechoic. You can see the amnion and part of the immature. That's a nice crown rump length. And then we have that really pretty rhomencephalon right there. So we see that around 8 to 10 weeks, right in the head there. It's a normal structure, and it will become the 4th ventricle after about the 11th week. So then, of course, we're not going to appreciate it in the same way, but you're going to start to be able to see the lateral ventricles and more of the brain structures around that time. So again, just something to be aware of so you're not concerned when you see this big old fluid collection in baby's head here. Okay, so let's talk about failed pregnancy. In my opinion, quite likely the most important part of early OB ultrasound, because we want to make sure that the patient doesn't need intervention. So some signs of failed pregnancy. So this is a pulse wave, the one I said not to use on baby here. So when you have a live fetus, again, we want to try to use that M mode to pick up heart rate. And as long as you're able to obtain it with that, that's great. No need to use a pulse wave. If you're not seeing a heart rate with M mode and you're not sure you want to make the leap of a fetal demise, then you can always use that pulse wave or drop a color box on there. Things you would not want to do on a live fetus, but when you're trying to make that critical determination, that's what this is. So they drop the pulse wave right where baby's heart should be, just to show that there are no fetal heart tones. And that is definitely something that's a lot easier to see when you're scanning live. You'll know that there's no movement in there. You're not going to need pulse wave to show yourself that there's no fetal heart tones. You will be able to see lack of heart tones on the ultrasound yourself. This is a totally fine way to document that, though I often document this way on fetal demise, just to show beyond a reasonable any doubt that there's no fetal heart tones there. So if you're seeing a crown rump length that's greater than 7 millimeters, or a mean sac diameter greater than 25 millimeters, or just overall lack of progression, that's when we start thinking about fetal demise. Just looking at this image right here, you can see that this crown rump length is pretty big. It's about the sizes that we've been looking at on all our other images. A size like that, you generally, I mean, especially if you zoomed in on that, blew that up a little bit, you could see heart pumping really good on a baby like that size. So when you're not seeing fetal heart tones here, I would confidently say there's been a fetal demise, unfortunately, because this is definitely a big enough fetus, a big enough crown rump length to be able to find heart rate on that. So some more fetal demises here, or missed abortion. I talked before about the gestational sac looking a little bit irregular. So most of the time when you see that gestational sac, it will have nice, round, full borders, almost like a balloon that was blown up. It's not always a circle. In fact, it's almost never a circle, but you don't see this kind of jaggedy lines on the edges. Right there, you can see those kind of wiggling down. I'm not 100% sure you guys can see my arrow. Hopefully you can. And on this third image, you can see it a little jaggedy on the sides there. It doesn't look like it's really full, like maybe it's starting to involute a little bit. We can appreciate the crown rump length really well. Can see it nice and big. If we blew that up a little bit more, we would see it even better. You can see the amnion. Oh, come on. On this first image, you can see it starting to come up around here. Actually, you can see it a little bit in all three of them. This is it here on the second. Here it is on the third. So we're seeing baby really well. We should be able to appreciate a fetal heart rate on a baby this size. But as you can see on this middle image here in the check mark, no fetal heart tones. They did do an M mode. Again, I see no problem using a pulse wave if you're more comfortable with that, especially in the case of a fetal demise. And we can see again on that third one. Now you can also appreciate, just notice the differences in the imaging. So let's go back really quick. Look at this baby right here. you can differentiate between the head is a little bit bulbous, and then we come down here, the abdomen, you can see the nice rump there. That imaging is really nice, crisp, clear. There's no big gap right there. And then come back over here, and it's just not the same. Like, there's no big bulbous head. It's almost like it comes to 2 points. You can just tell by looking at the images, it's just not quite right. And at that point, you would suspect fetal demise. Again, I think that's probably something that you develop after doing a lot of these ultrasounds. But even just after looking at quite a few pictures of them, you'll start to notice when things just don't look right. And then, of course, you're going to want to spend some time looking for that fetal heart rate, but we're not going to find it in this picture. So threatened miscarriage. If baby's heart rate is bradycardic at 80 to 90 beats per minute, so I guess that 90 to 100 is just like a concerning level. But if we're getting down in the 80s or below, that's definitely a concern that the pregnancy is not going to carry out. If the gestational sac is too small, if the yolk sac is really big and calcific, that would be a sign. But again, none of these are going to be clear, for sure markings. They're more just indications that the pregnancy may not continue and proceed the way that it should. We have small gestational sac on here again. If you see a large subchorionic hemorrhage, which is more than 2/3 of the gestational sac, and I want to point out again that this is not 100%. So we'll talk about the subchorionic hemorrhages. But my own child, I carried him to full gestation with a very large subchorionic hemorrhage. However, if it does rupture, and it'll depend on which side of the gestational sac that subchorionic hemorrhage is located. But it can take the gestational sac with it, essentially, if it ruptures. So that's definitely going to be a concern if you see a really large subchorionic hemorrhage. We have the amnion sign, absent poor decidual reaction. We talked about that. Again, these are all just kind of markers. So if you see a bunch of them, your level of concern might go up. Let's look over here. So a blighted ovum, that is going to be a gestational sac that never has a crown rump length within it. So baby never really grew in the gestational sac. So this is what it looks like. We see, again, the borders of this gestational sac really aren't super clear. But one thing I do want to point out is you're still seeing that nice, bright, double decidual reaction on here. At least that's what it looks like here. And this is one of those reasons why I don't ever leap to like, yay, you have a pregnancy and everything's developing great, until I see a crown rump length, because it can be a pseudosac, it can be a blighted ovum, it can just be some fluid within the endometrium that just happens to look like it has a bright lining. And this one even has an amnion and a yolk sac. You can see both of those little structures. There's the amnion. Here's that big yolk sac. And then this is a pregnancy that no crown rump length ever developed. So you're still going to have an elevated HCG. So on your blood test, or if you use the qualitative test, you're still going to have a positive HCG. So let's just look at some of the points here. Blastocyte is formed from a fertilized ovum, but the fetus never develops. Histologically, some fetal material can be demonstrated in most cases. Likely, if we were to be able to sweep through this imaging here, we could see some almost kind of debris areas where baby may have started to develop, but just never carried through. So once you hit a mean sac diameter of greater than 25 millimeters, you're going to want to go ahead and call a missed pregnancy or a blighted ovum. because baby's not going to develop. Most of the time, these will abort themselves, but sometimes they need a little extra help. A demise of a twin, pretty uncommon, 6.5% of the time. Twin pregnancy with one twin having an absent heartbeat and often being smaller than the live fetus with oligohydramnios, which is, of course, lower fluid volume around that baby. In some cases, only one fetus may be identified on ultrasound of a previous documented twin pregnancy, and this may be due to reabsorption or miscarriage of the demised twin. And we sometimes refer to that as vanishing twin syndrome. We have some images of those here in just a second. Some complications associated with demise of twin embolization syndrome, where the surviving healthy fetus is a monochorionic co-twin demise. And then surviving co-twin is at risk of developing growth restrictions, cerebral encephalomalacia, and microcephaly. It's a hard one to say. Okay, so demise of twin, this is really easy to see right here. You can see the fetal pole right here, and we can't see the other baby. Well, you can see how big baby is in this middle picture here. But on the left picture, we're only getting part of baby. So definitely some differences in developmental stages between these two. If you were to try to obtain a fetal heart rate on this, try to sweep through it, identify head versus abdomen versus rump, there is not going to be clear differentiations like we've been seeing in some of our other images. Some people call it, again, vanishing twin. This one's kind of nice to visualize because it still has a decent amount of fluid in here, amniotic fluid, making it a lot easier to see the other fetus next to this one. Oftentimes, it does not have that much fluid, especially in one that died so early on. But that makes it a lot easier to see. You can see the different sacs here as well with this nice little line there. And then we have the developing baby right here, significantly larger. And then here's just one more picture of that other crown rump length. That looks a lot like what we talked about before in those crown rump lengths undergoing a demise. So subchorionic hemorrhages. These are extremely common in early gestation. I see them probably 90% of my ER patients. Granted, most of my ER patients are coming in for vaginal bleeding with pregnancy, and a good portion of that time it is because of these subchorionic hemorrhages. So the hemorrhages just form during development, and then sometimes they will bleed out a little bit. Sometimes they don't. Sometimes they'll carry on, or sometimes they'll bleed a little bit, and then the subchorionic hemorrhage will grow, and that's when we're really worried about it. If the subchorionic hemorrhage is just there, just kind of sitting there, it's not changing, it's not growing a lot, there's a good chance they'll progress through the pregnancy with that hemorrhage without complications. But just talking about location of this. So if we look at this bottom left image here, just to touch back on, this is going to be a transabdominal image. Here's our bladder up here. This is our vaginal stripe coming out from the right side of the screen, turning into the cervix right here. This is going to be the fundus down here. We have myometrium. We have gestational sac right here. That anechoic structure, we can see a part of the crown rump length right here. And then right up here, you see this other dark area that we have not been seeing on our other images. This is going to be that subchorionic hemorrhage. So you can imagine if this hemorrhage starts to bleed down through the stripe here and out through the vagina, there's a good chance it's not going to cause any disturbance to the gestational sac here because it's not in the way. It's able to just release and go on its merry way. That's difficult to determine on this image. I'm not sure if these are all the same case. I think they might be actually. Yeah, they all look like the same case. So we can see it in trans here. It's anterior to the gestational sac, but this is really the image that's going to help us determine whether or not the subchorionic hemorrhage is going to cause it, is going to threaten the pregnancy. And I would say based off of this imaging, it's very unlikely to threaten the pregnancy. Again, we're going to want to see it a lot bigger before we have any major concerns about that. It can, however, be really reassuring to mom if you can tell her that there is a subchorionic hemorrhage. You know, you might actually have more bleeding if you're just having little bits of spotting. Not going to be super concerning. It's kind of to be expected at this point. And then just check back in, you know, if it does get to be a lot more than that. So let's look at the next one. So here's some more subchorionic hemorrhages. This first one is trans, so we can see it right here. You can actually see it's not always just hypoechoic. So that dark black, sorry, I'm using hypoechoic and anechoic interchangeably. At this stage, I'm using them fairly similarly. It just means that dark color. So we can see the dark here, and we can actually see that there are some low-level echoes within this subchorionic hemorrhage. That's likely indicating that it's just starting to coagulate. So more liquidy blood, more recent blood before it starts coagulating, it's going to appear dark because it's more fluidy. And as it starts to clot and sort of stake its land there, you'll see some low-level echoes within it, which is what we're seeing right here. And then we can see this other image up here. This is a really small subchorionic hemorrhage, at least in these two dimensions. Not very big. You can see some low-level echoes in there, especially on this bottom one. Low-level echoes right in there. But let's look back on the positioning here. So this is an endovaginal image. We can tell because of the way that the image is shaped. It's got that nice tight curve right here from the EV probe. There's our cervix coming down. This is an anteverted uterus. We can see fundus here. Here's our nice anechoic gestational sac right in the fundus where it belongs. And then you can see this subchorionic hemorrhage lying on this side of the gestational sac. So it's harder to trace exactly where we're going. It looks like probably right here, because this is the cervix. That little dot right there, that's a Nabothian cyst. Not concerning, but it just kind of helps us determine where the cervix is on this picture. So this fluid, if it's going to leave, it can probably leave without any problems because the gestational sac is over here. If it was really, really large, it would still be concerning that it would be causing problems to the gestational sac, just because a disturbance of something leaving the uterus that large could definitely have a negative effect on the pregnancy. But this one most likely is just going to kind of trickle out. If it does, it might just coagulate because it kind of looks like it is in this picture, and just not cause any problems and persist through the pregnancy and then leave when baby is delivered. Okay, so ectopic pregnancy. This is one of the biggest concerns, like I've mentioned a couple times, probably getting tired of me saying that. This is something that can be hard to find on ultrasound. It really helps to have some experience. It really helps to know what normal looks like, to really be able to pick up the fine points of what abnormal looks like. So we'll kind of be putting some pieces together from what we talked about before into this image. So on the left here, we have a transabdominal image, and on the right, transvaginal image. So the first thing that you see, maybe first thing that I see, is all this fluid. So this is that posterior cul-de-sac that we talked about. You can see some of the anechoic fluid right here, but if you look closely, some of the thicker clotting debris-filled fluid of this blood has kind of sank to the bottom. So there's actually fluid coming way back here behind the cervix, all around here. So this is really something that you got to pay attention to, because there's all this bowel down in here. And if it's not moving and if it's not just really echogenic, like all this bowel out here, it might be fluid and it might be a hemorrhage. So if you just see like a tiny little line of fluid, not really something to be concerned about. But when it's big like this and it's got some different levels of echoes to it, there's a good chance that that's blood. So you can actually see some right up here by the fundus as well. Just tells me that there is a lot of blood if it's not just accumulating in the posterior cul-de-sac. So this particular pregnancy, or this patient had an elevated HCG. And if we're looking at the endometrium on this one, remember how we talked about our bladder needing to be distended to really be able to see the endometrium really well on transabdominal imaging? It is not distended in this image. I'm sure this was an ER patient and we just take them back as soon as they come in. But ideally, this bladder would be distended all the way down, which would cause the fundus of the, just a second here, which would cause the fundus of the uterus to stretch out, and you would be able to see that endometrial lining a lot better, which we do not see here in this image. But just moving on to the second picture, you can see the endometrium pretty well, and there's no gestational sac in there. So you can see the endometrial lining. Realistically, this should have been stretched out a lot better so you could see the cervix and follow it down a little bit better, but that's what we have here. But you can quite clearly see that there is not a gestational sac within the endometrium here. You can see this fluid a lot better. You can see that it has debris within it, which is going to be super concerning for blood. With this much fluid, this patient is almost definitely bleeding somewhere. So these are very concerning findings on a patient with a positive HCG. Let's keep looking here. So same patient. Let's look at, maybe it's not the same patient. I think this one on the right is the same patient. Let's look at the ovaries. So back to what we talked about earlier with the ovaries, this is why it's really important to know what a normal ovary looks like so that you can recognize an abnormal ovary. So this normal ovary on the left here, we have trans left ovary, sag left ovary. You can see that they measured it in this image here. Looks like a great ovary. You can see these nice dark little follicles. It's not measured right here, but that's it. Right there, that little ovary right there. It can be a little bit hard to pick out, especially on just a 2D picture. A lot easier to find in real life when you can actually sweep in and out of the ovary. But this is a very normal appearing ovary, and we're still seeing a lot of that free fluid out here in the adnexa. Generally, if you see a lot of it on one side, that's probably the side that has the problem. This patient has extensive free fluid, blood, so we're kind of seeing it everywhere. So we're seeing it on the left, in the middle, and then let's move to the right. This is what we're seeing on the right. So increased blood flow as an indicator of an ectopic. We call that the ring of fire. And in these images, I don't actually have the right ovary demonstrated. I'm not sure if it was visualized or not, but the important thing is that we visualized an ectopic. So you can actually see in this one, let's move over to the far right picture here. You can see a gestational sac within this ectopic pregnancy. You can see a yolk sac, that nice bright little circle there. So in my mind, there is no question. This is absolutely an ectopic pregnancy. We have many of the markers. We have the free fluid in the pelvis, the blood. We have the ring of fire on the right side. We have a gestational sac and a yolk sac. So we were really checking the boxes on this one. This is definitely an ectopic pregnancy. And it's partially ruptured. So a full rupture of an ectopic pregnancy is you won't be able to identify this structure anymore. So, I mean, I guess it's not really ruptured, but it's bleeding. And if this ruptures all the way, this patient is probably not going to make it. So they'll need some surgical intervention right away. So live ectopic pregnancy in the adnexa, these are not super common. Most of what I see are probably ruptured ectopic pregnancies. If you're able to see one with live with a heart rate, you know, it's even more obvious that this is absolutely an ectopic pregnancy. But just because you're not able to find this, don't rule that out, because it's really not that common. But you can see the fetus here. We're not in the uterus, we are in the adnexa. They even were able to obtain a fetal heart rate. You can actually see a nice one on that M mode there. This one's really easy to visualize. But yeah, that's a very obvious ectopic. All right, case number 2. So let's see, the endometrial appearance in ectopic pregnancy. This is another one of those indicators that can really make the difference in an ectopic pregnancy, because in all these images that I'm showing you today, it seems like it's really easy to find. But I did one of these just a little while ago where I followed up from, gosh, like a 15-year veteran technologist who does these all the time. And she missed the ectopic, and I scanned it 8 hours later and saw this huge ectopic. So one of those things that are really important to understand is looking for some of those other signs. If you have an elevated HCG, really elevated, or you have serial exams, just looking at this endometrium, it's thick, it's heterogeneous. We're going to see a little bit of fluid oftentimes within here too. And the fluid isn't going to look like a gestational sac. You can see a little bit of a trace right here along the edge of that endometrium. And it just looks heterogeneous and complex. So not something that you're going to see on a regular gestation. And I think it almost looks like there's a little bit of free fluid. Yeah, there is a little bit of free fluid down here in the cul-de-sac that just kind of got pushed down by this bowel sitting right here. Here's some more bowel. It's a little more clear in the EV image. You can see it right here at the top right of that little screen on the right. Just some free fluid in the cul-de-sac. So some more images of the same patient. Let's start with the endometrium. It's thick, it's echogenic, but it's got this more hypoechoic center. This is another ectopic that is quite easy to identify. I mean, you have the ring of fire, you have a fetus, you have a yolk sac, you have a gestational sac. You have all the things, but assuming we did not have all the things, or if this was ruptured and now it's just blood everywhere, then we're going to want to know what to look for in the other signs. But since we have all the things, let's talk about this top right picture, because you can actually see the ovary and the gestation in the same picture, which is pretty cool and very unusual. So this ovary, we know it's the ovary because we see these dark little follicles within the ovary. If we could live scan this, we'd be able to sweep in and out of the ovary, both transverse and sagittally. And then we have this full gestational sac, yolk sac, all the things. We have free fluid on the sides here. So this is not a ruptured ectopic, but it's definitely bleeding. Some pretty cool images there. Not something you really see a lot of, just quite like that. So here's just one more picture of that. This is actually an 8-weeker. That's pretty big for having not ruptured yet. You can see, man, you can even see the rhomencephalon head right here down to baby's rump. Full gestational sac. Yeah, it is a Developing fetus. Okay, case 3. So here's some more of that endometrium with an elevated HCG. You can see, here, let's just walk through this. So cervix, this is a retroverted uterus, so it's flipping around backwards. It makes it squiggly and it makes it hard to get good pictures in this EV study. If this is a small patient, your imaging would benefit greatly by filling the bladder and just imaging transabdominally. That's not always an option, but it would be a huge benefit. So you can see some hypoechoic areas representative of some fluid here, some more fluid here. This is essentially, it's just not a normal appearing endometrium. It's complex with an elevated HCG. This is a huge concern to me that there may be an ectopic. If there was an IUP, it wouldn't be developing like this. We probably would have miscarried by now with this much fluid in here. Sometimes the patient is bleeding. I mean, if this would have to be a miscarriage, like a full bleeding miscarriage, to be able to look like this and have had an intrauterine pregnancy at some point. So let's go out to the adnexas. Here we have a very normal, luscious right ovary, nice and big, all these beautiful follicles, very fertile patient. Not always quite that easy to find an ovary, but this one's nice and big. We have some nice, good measurements on it there. We're out in the adnexa. You can see some bowel out here. Now, if we go to the left ovary, let's look at the left ovary first. So if you pop down to this bottom right image, you can see the left ovary. This is probably the corpus luteal cyst right here. And then we can see the borders of this. You can see it in the image right above it as well. And then this stresses the importance of looking in the adnexa because there's our ectopic. Not nearly as easy to see as those last couple that we looked at. And realistically, the reason for that is, well, it's going to be some patient size. We still have a gestational sac on this one. We have a crown rump length, or I'm sorry, a yolk sac. So we still have a lot of indicators that this is, in fact, an ectopic pregnancy. It's pretty conclusive once you find this, but it's pretty easy to miss. So you have to work for these images here. If you just look at the outside of the ectopic here, it is the same echogenicity as the surrounding bowel. So that's a lot easier to miss than you would think. It just really blends in, especially if we didn't have this nice gestational sac. If that hadn't fully developed or if it had collapsed and started rupturing, this would be very difficult to find. I sometimes have looked for 20 minutes for an ectopic pregnancy because I am convinced that there is one. And again, that's going to be based off of the fact that the patient has an elevated HCG. They're in a lot of pain. Their endometrium has that complex-ish appearance where it's thick, but it just has kind of like a fluid lining instead of having a gestational sac. So these are all signs that there's probably an ectopic in there. And you kind of have to dig for a while and really learn the landscape and make sure that there's no areas like this that really honestly look like bowel and could be easily mistaken for bowel if you don't take the time to thoroughly evaluate it. So same one here, we actually are able to see that crown rump length. The ring of fire that we talked about before, that can be an indicator of an ectopic. You kind of have to be careful with that one a little bit because we'll see increased flow to a lot of other things as well, especially if you're looking at the ovary and you're trying to call an ectopic in the ovary, which actually is not that common. It's pretty uncommon to have one in the ovary itself, but you'll easily get some flow there within the ovary. This one has a partial ring of fire. I'm not sure what their scale is at. We might have been able to get that a little better in a different view. But this is already quite clearly an ectopic pregnancy, crown rump length, the whole thing. But still, if this was collapsed a little bit more, man, it sure blends in with that surrounding bowel. And there's our nice ovary right next to it. So you can be sure that we're not looking at an ovary here. All right, case number 4. So I really like this endometrium. They're not quite that obvious all the time, but you can see the change in the endometrium appearance here. This one's maybe a little bit more extreme, but it's quite clear that there's not going to be an IUP within this uterus. But if you're just looking transabdominally and you just slap a probe down there and you see this image here, so this patient was a little bit larger of a patient, kind of hard to really get some good imaging. Bladder is really empty, so that's not going to help you out there. If you don't have the ability to do an internal, you could, of course, fill this bladder up, push that fundus down, and then we're going to see this area a lot more clearly. It almost looks like we have a double decidual reaction, at least on that more distant part of the gestational sac. Again, this is just the transabdominal imaging, but we don't see anything else. Of course, we don't see a crown rump length, and we don't see a yolk sac. But when we switch to the EV, you can really see that this is in no way a gestational sac. It's just the shape of the endometrial canal. This might be some blood in here. Probably it is. It's just settled differently, or a clot. Kind of looks maybe like a clot, but it's definitely not an intrauterine pregnancy. Something else that we're seeing on this image, let's come back over to our transabdominal image. You can see it right there, right behind the cervix. So just remember, when you're in that transabdominal image, your uterus comes down like this and it banks a hard right. So right there, the cervix. So this is not cervix. This is not part of the uterus. This is blood down here, which is also what we see here, is blood. Complex blood, anechoic blood, all the things. And you can see a little bit of the bladder just above the uterus right here. Yeah, so this is actually that case that I followed up. This is the second ultrasound that she had had. I think she left and then came right back to the ER because she was in so much pain. Still had that elevated HCG, and there's no way that there's a pregnancy forming in here. It's not happening. So if that's climbing, it's got to be somewhere. So here's some more pseudosacs. They're kind of going away from the word pseudosac, but essentially we're still looking at the same thing there. Transabdominally, it can easily look like a gestational sac. Honestly, even endovaginally right here, that could be mistaken for a gestational sac. And just due to ultrasound characteristics, you can still get that bright line there. We don't have the hypoechoic line on the other side, which is what we talked about with the double decidual reaction. But we definitely have the bright line on one side, and that's just going to be due to the change in speed of the ultrasound waves as they go through the fluid and hit that lining on the other side. It's going to cause it to look bright like that. We get a little bit of enhancement behind it as well. But these are not true gestational sacs. So you don't want to make that leap and call that a gestational sac and miss a potential ectopic pregnancy. So here's some transverse uterus images here. This is a transabdominal. You can see some contents within the uterus. It's the uterus again. Here's a nice right ovary. Looks really pretty. This is that hypoechoic mush in the uterus that we saw before that could, again, easily be mistaken for a gestational sac, but we don't want to do that. We see a nice right ovary, nice clean there. You can see little bits of follicles in there, but this is a transabdominal image, a little harder to see. So now when we move over to the left, of course, we want to identify a nice left ovary. But looking at this, it doesn't look clean like the left ovaries that we saw before. Uncertain whether this is ovarian tissue or some sort of complex mass, potentially an ectopic pregnancy. So again, clinically, we're going to have to kind of weigh the options on that one. Nope, that's the last one I have. So when we're looking at this here, we have a patient who's in a lot of pain with an elevated HCG. They have that complex endometrium. This right here, all that stuff in the endometrium. They have blood in the posterior cul-de-sac, and they have this big mess in the left adnexa. So it walks like a duck, it talks like a duck. It's probably going to be an ectopic pregnancy. It doesn't have that nice, clean appearance that we saw before, where we were able to see the gestational sac. We saw the crown rump length. We saw a yolk sac. We saw all these things. We're not able to see that on this patient. Patient's a little bit bigger. It may even extend further up. So remember, this is where our probe is, getting further and further away. Kind of hard to see what's way down here. But this is likely the remnants of a ruptured ectopic. And this patient's pain was just growing and growing. All this blood in here, you can see coming down right back here in the posterior cul-de-sac. So there's a lot going on here. And it's not looking very normal. So this patient did go to surgery. She got cleaned up and they read it out as an ectopic pregnancy. Even though it doesn't look clean, it doesn't hit all the markers, there was certainly no ring of fire on this picture. But she still had an ectopic and she probably wouldn't have made it a whole lot longer. So a hydidiform mole, molar pregnancy. Pretty common, actually. I don't see as many of these cases in the ER just because you don't present with a lot of symptoms, but definitely still something that needs to be cleaned out. You're not going to have a normal pregnancy. Partial moles, definitely more common than a full hydidiform mole pregnancy. You can see, let's go back to this is just our transabdominal image. You can see the cervix coming right up here. And this is going to be your intrauterine pregnancy. You can see the amnion right there. If we swept through more, you might even be able to identify a yolk sac or a crown rump length. Who knows? Doesn't really matter because we have this big old partial molar pregnancy over here. So this is going to have to get cleaned out, D&C. This pregnancy is not going to make it. You can see right here, this is a complete molar pregnancy. We don't have that hypoechoic, anechoic gestational sac anywhere in here. Just a lot of like cystic stuff growing in the uterus here. You know, like, honestly, it almost looks like an ovary with all the follicles, but it's not. So I have only had like a couple hydidiform moles, and I think mine lit up even more than this. This is a little bit older of a machine, it looks like. But you can even see just on this near field, you can see a lot of vascularity in here. It can fill up even further if you have a slightly more powerful machine. This looks like a partial because we have the sac here. Sometimes the partial hydidiform moles are really small. One of my coworkers had a partial hydidiform mole and we didn't even see it. It was very small, but it still caused a miscarriage for her. Pretty much any amount of molar pregnancy is going to cause that, and generally will require a D&C just to get all of that tissue and material out of there. So something you want to be looking for is all those little hypoechoic areas adjacent to the gestational sac. Hard to find when they're really small, but pretty obvious in these pictures here. I guess that was the end of it. Let's go back over a few of these. No, I didn't quite hit my 2 hours. So we'll just touch back on a couple here. these are some helpful slides. I think you guys have this PowerPoint from last time. I would suggest, just kind of like familiarizing yourself with what is normal, just because it's going to make it so much easier to recognize some abnormalities when you're used to the normal appearance. So if we're just looking straight at this image here, it's going to be concerning because you just see that little bit of fluid. Your first thought when you see this picture should be, is this a real gestational sac? Is there some bleeding around this uterus? What does that fluid really, truly represent? And again, don't make that leap that it's truly a gestational sac with a crown rump length until you see it, because it could easily still be an ectopic pregnancy based off of that little image there. Let's go back through this here. You actually have a subchorionic hemorrhage on this picture. Now that we've already talked about that, because you can't see the cervix in this picture, I'm betting it's obviously it's not more fundal than the gestational sac. Probably still gonna just leave on its own just fine. But now we can see that there. We see a bunch of bowel around the edges there. Nothing too exciting here. Okay, so now that we're used to looking for fluid, there's some fluid right down there. Not something too concerning because it's just trace fluid, so I wouldn't be worried about that. But just so that your eyes see that, here's our nice endometrial stripe. Of course, this is also just a pelvic patient that's not pregnant, so just a little bit of fluid is really not abnormal, but just so you see it there. See anything interesting here? This over here is not a subchorionic hemorrhage. These are just vessels, dilated vessels within the uterus, within the myometrium there. If I'm a betting person, this is a multigravidas patient. After having a single pregnancy, you often develop these bigger vessels within the myometrium. Pretty common to see. Just be aware of your location when you see that. You can put a color box on there. The flow is generally pretty slow, so you might not really be able to pick up like some venous flow in a vessel even that big, because it's not, it's moving pretty slow in there. You might be able to pick it up, maybe not, doesn't matter. We know that it is not a subchorionic hemorrhage because it's way out in the myometrium and it's not subchorionic. See if we see anything in here. Something to notice in here is there's like a little bit of debris in this image, which you can see, which is outside the amnion here. Maybe not super concerning. If we see some other factors, then that might be something concerning for like a missed abortion, a fetal demise. But if crown rump length looks pretty good and everything else, we'll probably carry through just fine. But just to notice, you can see a little bit of echogenicities out here. That's just some debris. Let's look over here. So we can see right in here, these again are just those vessels. And when you're scanning, sometimes you can see some turbulence within the vessels themselves, just that blood slowly swirling through. That can just help you determine the difference between vessels and a subchorionic hemorrhage. Now, if you look on the top right of this one, that's a little subchorionic hemorrhage right there. Right there. Which again, it's not going to be very concerning considering the location and the size, but just something for your eyes to see. We see them on so many patients and they're just not concerning until they're bigger. Here's those nice ovaries again, that corpus luteal cyst here. It really does help just to familiarize yourself with normal appearing ovaries so you can differentiate that between an ectopic pregnancy. You will get many of the same signs as an ectopic pregnancy and could easily call an ovary an ectopic if you're not super familiar with normal ovarian tissue. I don't generally Doppler an ectopic. I would think it would be more, lower resistive than an ovary though, because it moves pretty fast. Nothing super exciting in these ones. These are vessels down here behind baby. Hard to say really what this little hypoechoic line is there. Probably just another vessel. Ooh, here we go. Right here on the left one, that one looks like a little bit of a subchorionic hemorrhage right there. Not super concerned. Looks like it's already clotting. Probably going to be just fine, but just so that your eyes see that. These here are vessels, nice big vessels. Subchorionic hemorrhages are not always like a nice scoop. Sometimes it'll be like one area connecting to another area. But if you were to scan this live, I bet you would see a little bit of swirling in here on these vessels. Nothing too exciting there. You see this nice smooth myometrium here. This is a different machine. This is a GE. It's nice and pretty. My pictures are all Canon, so they're gonna look a little bit different. But this one's really smooth on that nice, probably a Voluson GE there. Look back through this picture here. So this is probably the amnion. This is not a super clear picture. It was a great picture of the rhomencephalon. Not a great picture in other regards. It almost looks like a twin pregnancy, but it's probably an amnion, and this is probably a corner of the yolk sac. Again, this would be super clear if you were scanning it live, but since we don't have that luxury right now, that's what we're looking at there. Nothing to see there. So this might be a subchorionic hemorrhage. You can see it in multiple different views. This is just some lateral edge shadowing. So the way that the sound beams travel through, sometimes you will get this lateral edge shadowing. And if you were to switch your angle across and come at a different position to that part of the uterus, that would go away. But just be careful about that, because you can get some lateral edge shadowing just the way that the machine works. This, again, probably a very small subchorionic hemorrhage here. Doesn't make really any difference because unfortunately we have a fetal demise in these pictures. Go back through some of these, see if we see anything exciting. I don't see any major hemorrhages or fluid collections on those. Or on these. Nope, just see some bowel back here. These are these are not great pictures. Ideally, you want these to, there's a lot of artifact in here. That's why it's so gray right here. But really, you want to try to clean that up, whether it means changing your angle, trying a different probe if you have it. But this almost makes it look like there's something here, like some blood or something, but it's just some reverberation artifact. Back to our subchorionic hemorrhages. Don't forget you have your vessels out on the side here. This is going to be your right iliac artery. Not sure what this is here because we're sagittal, but these are your iliac arteries out here. So when you're looking around for your regular ovaries and you're looking for your follicles, you just have to be aware that there are vessels out there as well. And it's tempting to see this image here and think, oh, that must be a cyst on the ovary, or maybe that's my corpus luteal cyst. But if you simply turn on that sagittally and elongate it, or drop a color box over there and you'll see it light up with color indicating a vessel, you can roll that out pretty easily. Some more subchorionic hemorrhages here. Don't see any free fluid to look at though. Just those little hemorrhages. Let's see what else we have. Any more free fluid? There's our big free fluid. That's the one we talked about before. You can see the different levels. Again, just looking at this fluid right up in here, you can really easily see all that debris within that free fluid in that area. And right down in here, this is all fluid here. This is bowel. You can see the bowel wall. But the fluid comes right up, right underneath the uterus, comes all the way down here. This is going to be just thicker blood. Free fluid all over the place. There's going to be free fluid on all of these. But again, here's that nice ring of fire. It just kind of goes kind of circular. Not the best indicator because I've seen many ectopics that don't have this. But it's a nice, helpful little sign if you find it. Free fluid everywhere. So let's talk about the M mode on the heart rate on this picture. In theory, it should be exactly across the screen on the M mode. So the way this is supposed to work is that we have the gestational sac here, right where it gets dark here, right where it gets dark here, and it should be across through our line here. So really this is kind of supposed to be across from there, kind of supposed to be across from there, and this is supposed to be across from here, all the way down to the bottom, right underneath, and then when it gets echogenic, that's supposed to correlate with the echogenicity on this side of the screen. Some machines I've used don't quite work that way when you use volume. So if you blow up on the right side of the screen to make it bigger so you can see that heart rate better, it doesn't blow up at the same rate on your M mode. So you have to be a little bit careful about that. Whatever machine you're using, it might correlate exactly across the screen like that, but it might not. Kind of just have to learn your own machine there. Here's all that nice free fluid back here, which we are also able to see up here. Free fluid all over the place. Right out here. Here's a bunch of vessels down here. So in addition to having your iliac artery and vein, especially in a multigravitas patient, you may also have some pelvic congestion. I didn't really touch on that because it's not really OB for sure. But when you're looking for ovaries, it's helpful to be aware of. So just looking at this picture right here, you can see there's a vessel here, there's a vessel here, this top right picture, here, 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 coming across here. This patient probably has pelvic congestion. And if we were to drop our color box right in here and decrease our scale, these would likely fill with color. Pelvic congestion can, of course, cause pain at other times, not ectopic pain, but definitely some pelvic discomfort. So it's not necessarily something that we are looking for on OB ultrasound, but it's absolutely something to be aware of when trying to identify structures. Like ovaries, if you can turn transverse on this, you can make them all look like follicles. But they're not follicles, and if you drop a color box on them, they should light up pretty easily. Or if you turn the opposite direction, you should see at least a couple of them elongate. Sometimes they're pretty tortuous, so it's hard to get them to really elongate out, and they'll always almost look like little dots, especially if you look on this top left picture, they almost look like follicles. But this is that pelvic congestion. This is all those vessels in the adnexa, and we don't want to mix that up for an ovary. Oh, one more thing. If you were to take a power Doppler and obtain a resistive indice, like wherever those ovary pictures are, right here. If you were to do, I don't know where it is. If you were to do one of those on one of these vessels out here, it would be super high. You would have a very high resistive index, probably like 0.8 or something, which helps determine that you are not in the ovary. Just look at some more free fluid in there. You can see it coming across. It's a lot easier to see when it's fresh fluid because it's that nice hypoechoic line. Just remember, the longer it's there, the more likely it is to have been coagulating. So it's going to have some debris within it, or just be isoechoic with the surrounding structures. It can make it kind of hard to identify sometimes, but it's super important. Here's that isoechoic ectopic again. Like, super easy to just sweep right past that sucker. But that's quite clearly an ectopic when you dig into it a little bit more. So here's some, this is a nice one. So just looking up at this picture right here. So here's our uterus in the top right of this bottom right image, just in case you can't see my arrow. There's our uterus. Here's our endometrium, the echogenic area in the middle. We see it kind of come out to a peak on the side. Then the fallopian tubes are wrapped around just like that. You can almost imagine right where they go because we have an ectopic in the middle. And then here's our ovary right down here. These vessels here are just pelvic vessels. It might be some pelvic congestion. I'm not sure how big they really are if we would get to that point, but it would be super easy, and I have seen it done many times, to just call this an ovary right here. Just throw some calipers on that and call it an ovary and be done. But we would have missed all of this, the ectopic, the ovary. So be really careful not to call these follicles and call this an ovary, because then we'll miss the ectopic altogether. There's that same picture we have on this one. There's that nice thick fluid. This is a really nice one because you can see the difference in the new blood and the old blood. But this poor patient has probably been bleeding for days. Just kind of have that in there randomly. There's that nice right ovary, nice and normal looking. It doesn't always have a bunch of follicles in it either. Usually you can find at least one or two to help you identify, especially in a patient that's pregnant, because they're obviously still fertile and a little bit younger. Those are definitely some vessels deep to this ovary. Could be the iliac, could be the same vessel and it turns a little bit there. Hard to say. Nice fluid there. All kinds of stuff. There's our molar pregnancy again. We don't see any free fluid in this patient. There could have been even a little bit of trace-free fluid. Again, remember, that's kind of normal to see just a little bit. It's when it gets more extensive and it's bloody fluid that is a lot more concerning. All right. Well, thank you guys. I'm sorry I wasn't able to join you live for the presentation this Saturday. I love answering questions, so please feel free to email me or anything if you guys aren't comfortable with something. Hopefully we went over that enough to help understand this process a little bit more. And let me know if you guys do have any questions. Not sure if I know how to get out of here.